All right, so I'm Halim. Nice to meet all of you. So typically, the way I like to do this is to go over those cases. We'll discuss them. We'll take our time with the first one. It kind of sets the tone for the rest of the cases. They're vascular cases, and I like this to be interactive. So keep your mics on, and we'll do it in an interactive way. Hopefully, this will give you an idea about what we do. Do you guys have had a chance to read some of those chapters?
Yes.
Okay, very good. So we'll start with the first case. This is you have a 55-year-old man who comes to your office and tells you that he has left leg pain when he walks. Let's start how you guys appear on my screen. Samit, what do you want to ask this guy?
How long has this pain been going on for?
It's been going on for a few months. It's getting a little worse.
Should I ask the next question, or do you want to rotate through? Or
Keep going.
okay. Did you mention where the pain occurs specifically?
I did not. It's in his
Okay.
calf.
Okay.
So, in his calf.
Do you mind describing what that pain feels like?
Feels that his calf is tight and it burns.
Okay. Have you noticed anything that makes this pain better or worse?
Yeah, if he stops walking,
Okay.
the pain completely goes away. If he continues to walk, it makes it worse.
Okay. Have you noticed that if there are particular distances that make this pain come on?
Yeah, he tells you, I don't know. I mean, okay, I don't measure the distance when I walk. How
Okay.
can you ask him about the distance?
Maybe I would say maybe for a person, like, does the pain come on when you walk to a mailbox, or like, have you noticed if you go to walk a couple blocks down the road, or
Right.
kind of use like a familiar marker for distance for them?
Very good. Very, very good. This is how I would say. I would say what I usually ask them is when you walk from the parking lot to my office, I would have an idea what the distance is. Did you get the symptoms, And or you can say, if I bring you in, if you want to, because sometimes patients are all over the place and you want them to really give you the details that you want because they're important. Then you tell them, if I take you outside and put you on this cross section and I'll have you walk, how many blocks can you go? Or tell me, describe it to me in details and things like that. Very, very good. So you're given basically what Samit here did is gave us all the questions everyone should ask anytime you have pain, okay? Any pain, abdominal pain, leg pain, everything is where is the pain, location, duration, when did it start, does it go anywhere, relieving factors, exacerbating factors. Every time you have a pain question, no matter where you're doing an abdominal case or a vascular case or leg case, you have to ask those questions because they make your life easy and help you have the stuff will be neat in your brain and very well organized so that you can go from there. Okay, so Jeremy, what do you want to know more from this guy?
I'm going to ask.
I'm just going to sum it up. He's 55-year-old guy. He walks one block and he has bad pain in his left calf. And when he stops, the pain goes away.
Okay. I'm going to ask you a couple questions about your past medical history. Have you been diagnosed with anything in your past?
He has no medical problems.
Okay. No hospitalizations or surgeries?
No surgeries, no hospitalization.
Okay. I'm going to quickly try to sum up your social history. Do you have a history of smoking?
Yeah, he smokes a pack a day. He's done it for 20 years.
Okay. Do you consume alcohol, and how much if you do?
Occasionally.
Okay. I'm going to try to move into, well, can you tell me what you do on a daily basis, your hobbies and your occupation?
Yeah, I mean, I wouldn't go into the hobbies. You trust me, you go to see a patient in clinic, you'll have like 20 minutes to see a new patient, you get them started, you'll never get them to stop. I don't know if this is not what they teach you in medical school, but this is real life, so, but family history is definitely important. And social history, like in terms of what do you do for a living, is important. And it's very important in our case. Why, Jeremy?
Because it could like be a reason for the problem, like a reason why he's experiencing this pain.
Uh, sure, but it's something like different. I had something different in mind. Ashley, any idea?
I was just thinking like the smoking is a risk factor possibly, or or also for like blood clots and stuff like that.
So why does it matter what the person does if they're having leg pain?
Oh,
Because sedentary.
yeah, it could affect their work and them not being able to make a
So if
living.
it's a mailman and they need to walk, and this is this goes into the treatment. So before you guys want to ask the guy something else before we do his medical history, like we did a little bit. He doesn't take any medication. He has no family history that is important. He smokes. He works at the airport. But did we want to ask him something else?
Like a review of systems.
Right. So it's very important to do a review of system, but you want to do a focused one, right? I don't want to like ask him about his hearing and his vision and all that stuff. But we're talking about vascular disease right here. We're talking about peripheral arterial disease, which means you have atherosclerotic disease in the blood vessels. A lot of patients that have peripheral arterial disease can have also heart disease, right? So you want to ask them, do you have any chest pain, any shortness of breath, any history of strokes, any history of TIAs or stroke-like symptoms? And then we'll talk more about those when we do the carotid, but it's all the same risk factors, right? For all those diseases. Atherosclerotic disease has the same risk factors and it can affect anywhere in the body. We're also looking here at the legs. So if someone, there's one more question that is extremely important whenever, nobody told me, what does this guy have?
Claudication.
Claudication, right. So there is a very important question to ask when we are dealing with claudication to patients because it will determine our treatment strategy. And this question is it affecting your job? Is it affecting your quality of life? Okay. If a person cannot walk from their front door to their mailbox to pick up their mail because they have to stop once or twice because of pain in their legs, I mean, I would say this is affecting their quality of life. But this is the patient determine what their quality of life is, and they can tell you what it is. So they can say no, and you can ask them, how active are you? Because a lot of patients will start doing less. So he will tell you, I'm okay. Tell him, how many times have you taken the stairs in your job? And I tell you, no, I take the elevators all the time because my leg hurts. So it's important to elucidate those details when you're also talking to the patients about it. Chest pain, shortness of breath, stroke-like symptoms are things that I ask every patient I deal with. And then I ask them a family history of coronary vascular disease, cardiac vascular disease, or bleeding or clotting disorders. All right, so we have all of his history now. What is next, Samit?
A physical exam.
All right, what do you start with?
I guess important to check out heart, lungs, and then
You want to get
check
some
out
vital
maybe,
signs first?
yeah, vital signs would be great as well.
So he's afebrile, his heart rate is 80, he's slightly hypertensive, his systolic blood pressure is 160, his respiratory rate is normal, he's standing fine on room air.
Okay. I guess there's a little bit of concern for the hypertension there. Then I guess next we would probably want to check peripheral pulses.
Sure, how do you do that?
Not sure what you mean, but I guess you could feel starting with like the femoral and then working down to kind of identify where maybe the claudication might be occurring.
Okay, so whenever we do a vascular exam, we check all pulses. Okay, we check the radial pulses in both hands. You can check brachial pulses. You check femoral pulses. Very important when you're checking femoral pulses to have the patient completely flat on their back. It's extremely hard to do, especially if someone is a little big, if they're not completely flat. You check popliteal artery pulses and you check pedal pulses, which is the DP, the dorsalis pedis, and the posterior tibial. The dorsalis pedis is typically on front of the foot. The posterior tibial is behind the ankle. So you feel for those pulses. If you cannot feel a pulse in the foot, Jeremy, is there any adjunctive thing that we can use in an office base or on the floor in a hospital to check for pulses or for anything like that?
You're talking about like an ultra.
The ultrasound is a big bulky, and you have to look at it at an image. Is there something else that we can use that is smaller, handheld, has a little probe? Doppler.
Okay.
Okay, so we use the Doppler, we put it at those blood vessels where you try to check, and you can listen for a signal. Yeah, I mean, this guy, we check his, we listen to his heart, it's normal. We listen to his lungs, it's normal. His legs, so when you're examining a leg for peripheral arterial disease, number one, you look, okay? You look, is it pale? Is it discolored? Is it red? Is it purple? Is there any ulcer? Is there any wound? Number two, you touch and you feel. Is it cold? Is it warm? Because if it's cold, it might not be well perfused. But if if he has symptoms in one leg but the other one, so you can compare the difference in the temperature. And number three, you check for pulses or you listen with Dopplers. So we checked on this guy, and he did not have palpable pulses on the right side, but his pulses were palpable on the left. And you checked with a Doppler, and you can actually hear some sounds on the right. So he has Dopplerable signals, but not palpable pulses on the right side. So Jeremy, what's next with him? What do you want to get on this guy?
Probably a CT angiography.
Is there something else you would like to start with? There's a test that you can do yourself, or the nurse can do.
Brachial index.
Exactly. The most important test in peripheral arterial disease, the way that we diagnose peripheral arterial disease, is actually ankle brachial index, or ABI. Ashley, do you know how we do that?
So you take, I know it's the ratio. You compare the ratio for the pulses in the ankle to the brachialis pulse, to the brachial pulse.
It's not a pulse. What is it?
Like the perfusion?
It's the blood pressure.
Yeah.
Okay, so you check the pressure at the ankle. So you put the cuff at the thigh or at the calf, and you inflate the cuff. You have a Doppler on the DP and the PT. You do one at a time, and you inflate the cuff just like checking blood pressure in the arm until you can't hear the signal anymore. And then you release it slowly until you hear the signal. Once you hear the signal, that's your systolic blood pressure. And then, you compare that, you divide it by the blood pressure in the arm. So this is what an ankle brachial index. What is the normal ankle brachial index?
1 to 1.4.
1 to 1.4. Everybody says different things. Typically, 0.9 is normal. So 0.9 to 1.2 is what we take as normal. Why do you think more than 1.2 is not normal? So it's because it can be falsely elevated. If someone has very calcified disease, they cannot compress, the blood pressure cuff cannot compress those blood vessels. So you can get a very high systolic there because you're not compressing the blood vessels, so it's falsely elevated. It doesn't mean that they don't have peripheral arterial disease. So usually diabetic patients have calcified vessels or end-stage renal disease. You mentioned a CTA. CT angiogram to look at the blood vessel is not wrong, okay? And we often get it these days, but there are a couple of studies that we get before that. The one of them you said is the ankle brachial index. What is another test that we can get?
Maybe like an arterial duplex scan?
What is that exactly?
I'm not sure. I remember reading up on it.
It's an ultrasound.
Okay.
Arterial duplex is an ultrasound with color flow, and you measure velocities. So you put the ultrasound and you measure the velocities inside the blood vessel. You look at the color flow. and it can tell you if there is narrowing or not, if there's a stenosis, if there's a blockage. It can tell you what kind of waveforms, it triphasic, biphasic, monophasic, all that stuff. It's a very good study. It's our second most common study after ABIs, and usually we get them in conjunction with each other. So we checked the ABI on this guy. It was 0.7. We got a duplex on him, and it showed that he has a 100% blockage in the middle of his SFA. It's about 1 centimeter in length. It's completely blocked, 100% blocked. So in this guy, so what is a fourth method to diagnose this as well? So we talked about a CT angiogram. We talked about an ultrasound duplex. We talked about an ABI. There's something else. An angiogram, right? You take him to the cath lab, you stick their blood vessel and you shoot some dye and you look at the blockages to see if they're, typically we do not start with that. We start with an ultrasound, and then if we need to, we can either decide if we're gonna get a CTA or if we're not gonna get, or if we're gonna go to the angiogram. So to the angio suite and do an angiogram and try to treat him if we need to. So
I have a quick question.
yes, sir.
So like, why would you get the ultrasound if you could just sort of skip ahead to the CT or the angiogram?
To the CT or the angiogram?
Like, why even go through the process of doing an ultrasound?
Because I'll tell you why. Ultrasound is an extremely, it's a much cheaper exam. It is very detailed and it has no radiation. So this is why you would choose this versus a CT as a first-line therapy, as a first-line treatment. So anytime you can choose between studies, you start with the least expensive, least invasive, and with least risk to the patient. And an ultrasound is that for this. But it is important, and I'll tell you now, it's a very good question what you said, but tell me, what do you want to do for this guy? Let's start with you, Jeremy. What do you want to do for this guy?
If I'm seeing 100% occlusion, I would probably take him into surgery and like do some endovascular surgery, maybe like stent it.
Stent it, okay. How about you, Ashley? What do you want to do for this guy?
Well, I know like the most beneficial treatment would be like exercise or like, so I guess I would at least try that.
Okay, what is exercise? You tell him go play basketball?
Yeah, medically induced exercise and just like, I guess trying to, I know like claudication improves with moving, and I guess if you do want to do surgery, you want to make sure that they are continuing to prevent that in the future.
Okay. How about you, Samit? What do you want to do?
I guess the only thing I could think of outside of what my peers said was maybe like smoking cessation, because we talked about how significant that was in terms of like progression.
So what
maybe
you
we can
guys are
start.
talking about are life modifications,
Mhm.
lifestyle modifications. Anything else?
Maybe some medications, maybe like cilostazol.
There's no maybe. You got to tell me what you're going to do.
I'll start with
Imagine I'm
medication.
giving you an oral exam right now, and I'm asking you, what do you want to do for this guy?
I'll start with lifestyle modifications and then medications, aspirin, statin, and cilostazol.
Okay. Everyone with claudication needs to be on optimal medical therapy before we touch them. Okay? Before you touch someone, you have to be on optimal medical therapy. Number one, a baby aspirin every single day for the rest of their life. Number two, a statin. Okay? A high dose, high intensity statin. This is atorvastatin, 80 milligram if they're younger than 74, or 40 milligram if they're older than 74, or rosuvastatin, 40 milligram if they're younger, or 20 milligram if they're older. Aspirin, statin. Number three, you can give them silastazol. There's some studies that suggested that it can increase the walking distance in patients with claudications.
Mm-hmm.
However, silastazol has a lot of side effects such as flushing, headaches, diarrhea, and patients who have heart disease and bad heart failure cannot take silastazol. So be careful, it might be a trick question in one of your exams. And then what you want to do is aggressive medical management of their medical problems. What did we diagnose him with? probably. Hypertension.
Hypertension.
You need to treat their blood pressure, or their primary care physician need to treat their blood pressure. If they're diabetic, you need to treat their diabetes. They need to be under good control. Then comes the lifestyle modification. Most important one is smoking cessation. You can offer to prescribe them medication to stop them smoking. Can someone tell me name of a medication to help with smoking cessation?
Perennicline?
Is that Chantix?
Yeah, yeah.
Chantix is the one that has been proven the most to help with smoking cessation. What do you tell patients when you prescribe them Chantix? Do you know of any side effects?
It's like it's a partial agonist. Forgot.
So people can go crazy on Chantix. They can have suicidal ideation. They can have psychosis. So you tell them if you experience any of those symptoms, you got to stop it right away. The other medicine is Wellbutrin. You can prescribe them Wellbutrin. Then there's the nicotine replacement therapy, patches, gum, all that stuff. So this is the risk modification. And then Ashley mentioned exercise. I mean, she didn't express it very well, but a supervised exercise program is what we prescribe for claudicants, which means it's a specific type of walking exercise that can help them build their walking distance and increase their walking distance. It works so well that actually Medicare now pays for it for patients to go to rehab centers to do the supervised exercise program, because it was shown if you tell patients to do it on their own, they're not likely to do it. But if someone is pushing them and standing next to them on a treadmill and supervising them, they would do it. So basically you tell your patient, if you want to tell them how to do it, is you go out and you start walking. Let's say you can go 20 yards and then you have to stop to rest. You stop and then you rest. And when you can go again, you go for 25 yards. And then you stop, you rest, and then the next time you go for 30 yards. And so forth. You do that for 30 to 40 minutes a day, 3 to 4 times a week. Okay, this is the definition of an exercise program for claudication. Okay, if someone asks. So every patient who has claudication, the Society for Vascular Surgery recommend medical therapy and do not recommend surgery or whether open surgery or endovascular intervention, unless the caveat is unless it's not affecting their quality of life. This is why I said, quality of life. What is the quality of life? So Jeremy, now you see why we got the ultrasound, because probably this guy, he tells me, no, it's not affecting my quality of life. I'm able to do whatever I need to do. I'm not going to offer him an angiogram. I'm not going to offer him a bypass. I'm not going to offer him anything surgical. So why do I need to get a CTA on him and give him contrast and give him a radiation, or take him and do an angiogram? That's why we get the ultrasound on them. So treatment of claudication is always optimal medical therapy, aspirin, statin. You can give the silastazole, lifestyle modification, smoking cessation, and exercise program. Now you do that for 3 months, and patients that usually walk longer distances do well. If someone comes back and tell you, then it's getting worse, I cannot do my job anymore, it's affecting quality of life, then you have options. You can either take them to the cath lab and do an angiogram, try to cross the lesion and put a stent or a balloon or do an atherectomy. We have multiple stuff to treat it. Or you can do a bypass, an open surgical bypass, and you can bypass that obstruction. Okay? Any questions on this? Do you know the terms? What do we call a balloon? What is it called when you balloon endovascular and you balloon a lesion? It's called angioplasty. Okay? When you say someone say angioplasty, it means they did a balloon they put a balloon across the lesion and then they inflate the balloon to get rid of the stenosis. And then stenting. Stenting is better than ballooning. Nowadays we have drug-coated balloons and drug-coated stent where they have paclitaxel mounted on the stent or on the balloon to help with neointimal hyperplasia so that the stenosis doesn't come back as fast as usual. Or you can do a bypass. When we do a bypass, we can either use a synthetic graft like Dacron or PTFE, or we can use a vein, the native vein from the patient. The great saphenous vein usually is the conduit of choice. If you need to do a bypass and you have great saphenous vein, it's the best conduit to use.
I have a quick question. When do you sort of consider putting them on sort of higher or more intense anticoags like warfarin or something?
So typically, antiplatelet therapy is what we use for claudication, okay? And there's no indication for blood thinners or anticoagulation. The indication only for single agent antiplatelet therapy, whether it's aspirin or Plavix. Usually we use aspirin as a first line. Now, let's say someone you treated and they have a lot of disease, you might choose to put them on anticoagulation afterwards, which is also not very supported by data. But most people, when patients have poor outflow, very diseased tibial vessels, and you did a big intervention on them, we would put them on anticoagulation. Now, if you stent somebody, you have to put them on Plavix for a period of time in addition to the aspirin, and then you can transition them back to aspirin, just like when you do with the coronary stents. Okay, I think we beat this case to death. It was supposed to be 15 minutes, but I like to take my time with the first case so that you guys know how the cases go, and then we can go quicker with the following cases, because you know that any arterial disease, atherosclerotic disease, have the same risk factors and the same medical therapy. And it's when you do surgeries when it becomes different, okay? And now this is the second case. This is a 65-year-old lady, comes to the emergency room crying in pain because it started all of a sudden in her right leg. We'll start the opposite way. Ashley, what do you want to know?
Okay. So I describe the pain that she's been having.
The pain is burning sensation, it's throbbing, and she also feels that her foot is numb.
And then you said this started suddenly. Did anything bring this on?
She was doing well. She did not have any problem. But when she, sat on the couch, she felt that her foot went cold and numb and started hurting her real bad. Started an hour ago.
Okay. Does she have any history of this before?
Never happened to her before.
Has she found anything that makes it better?
Oxycodone. Her sister had some at home. She lives with her. She took one and it helped her.
Is it worse with walking or?
She cannot stand on her foot. She has not tried to walk.
Okay. Anything else that makes it worse?
No, it hurts a lot. Please do something about it.
Okay. Are there any like outward trauma?
No history of trauma.
There's nothing on the foot? Okay.
No history of trauma. Do you want to ask her if she used to claudicate before?
Yes.
She never claudicated before. She's like, I usually, I walk. I go and walk 3-4 blocks. I don't stop because my legs. Sometimes I get a little short of breath, so I stop a little bit to rest. But that's it.
Okay. So, do you have any? Are you taking any medications for any diagnosed disorder?
Before that.
Okay.
What you want to ask her about her risk factors, right?
Okay.
I mean, we
before we go to medications, we want to ask about like smoking.
No, I meant you want to ask her about possible. There are some stuff that we like to ask about every single time because they can also be associated.
Okay.
So no chest pain.
Chest pain, shortness of breath.
No shortness of breath. No stroke. No stroke-like symptoms.
Mm-hmm.
Never had anything like that. This is with the history. All right. Very good. I think Jeremy. Now we have a 65-year-old lady who's been doing fine all week. Never claudicated before. Suddenly started having a cold foot that is numb, severe pain. 1 hour ago in her right foot. The left foot is completely fine. What do you want to know more?
Have you been diagnosed with anything in your past?
Yeah, I have hypertension. I have congestive heart failure. I have diabetes. Never had any surgeries. I'm not allergic to anything. I take a couple medications for my hypertension. I don't have any family history. I've never smoked a cigarette in my life.
Okay. Move on to the physical exam.
Very good. We don't waste time, right? What do you want to know?
Uh, First, I would probably check the pulse in that leg, see if it's
You
she
want to
has
get some vital signs first?
oh yeah, vital signs. Yes.
Okay.
So
So
yeah.
she's febrile. Her heart rate is 140. Her blood pressure is 160 over 90. Her respiratory rate is 12, and she's setting 100% on room air.
Okay, and then I would move on to sort of the physical exam, check her heart, check her lungs, and check her pulses.
Okay. I don't mean to pick on you. Try, when you guys speak, try to get rid of the sort of or maybe or things like that and just give an answer, because you gave the right answer. But when you tell me sort of, I feel like maybe you're not sure. So, very good. So yeah, the heart rate, you check her heart, and I read something in my book, and this sounds just like it. It's irregular, her heart rate. Her lungs are clear, her belly is soft. Look at her legs, there's no edema, but her right foot is really cold and pale, and I cannot feel a pulse, and I cannot hear Doppler signals in it. While the left foot is warm, and I can feel a strong pulse in it. Wow, this is weird. What do you want to get?
I would do a ABI.
Very good. The ABI is 0 on the right, and it's 1 on the left. Samit, what do you want to do more?
Well, I'm concerned with it being 0. It seems like there's no blood flow to her lower extremity, so I would think that that would be emergent, taking her potentially to the OR.
Would you want to know, is there some things that can help you figure out what's going on before you take her blindly to the operating room?
Could we let's do a CT angio beforehand?
CT angio is perfect here. More you can do a little bit more detailed physical exam, right?
Okay.
Feel the pulses like we talked about. We feel all the pulses, not just the foot. So you know what? Her femoral pulses are present, but I cannot feel her pulse in the popliteal on the right. I can feel it on the left. I think, what are we thinking this patient has? Does she have atherosclerotic disease?
I don't think so. The lack of claudication makes me think that it's less atherosclerotic, but the combination of her having both like AFib and like heart failure makes me think that there might be some sort of embolic disease.
Right. So this is what we're thinking, an embolus, right? So you're suspecting an embolus, what's the first thing you want to
do? Maybe do like a cardiac workup. I would think to do
an emergency, like you said. You went from wanting to take her to the OR right away to wanting to do a cardiac.
Yeah.
She needs a CTA. We already to go to the OR for sure. Okay, I don't want to confuse you. I'm not trying to trick you, but there's something you want to do before that. Ashley, what do you want to do for this patient?
Possibly, just thinking like an ultrasound.
No.
Duplex.
Jeremy, you just asked the question like 5 minutes before.
Would you give them IV heparin?
Yes, I would give her heparin.
Yeah.
Okay, this is the first thing I would do. She has AFib. She has a cold leg. This is embolic, right? So she has a palpable pulse in the other foot, right? She would never have claudications. You guys guessed it. You did good. You have to give them heparin. You bolus them. 80 milligram per kilo bolus, and then you run them as a drip, 18 milligram per kilo per hour, okay? And you send her to the CT scan. You get a CT scan, and you see that there's good blood flow. Our blood vessels are good. There's no calcium in our blood vessels. There's no atherosclerosis. You don't see any plaque. But all of a sudden, at the popliteal artery, blood flow completely stops. What do you want to do?
Do a bypass.
So from her popliteal artery down, she has no flow.
Okay.
What are you
You've given the IV.
Uh-huh. We're gonna
IV.
take her to the OR, Jeremy. What are we gonna do there?
Oh, what are we gonna do in the OR?
Yeah, we decided she needs to go to the OR. Anyone thinks she don't need to go to the OR? All right.
Yeah, I would do a bypass to bypass the embolus and get blood flow, return blood flow to the limb.
No, you can't. So what do you need to be able to do a bypass? You need inflow source, right? A normal vessel, and you need a target, an open vessel to hook the bypass to, right? She's has no flow from her knee down, which means I'm telling you she has no target. Plus the bypass, a bypass is the wrong answer here. Okay, Ashley. She has a clot.
Mhm.
What do you want to do with it?
I mean, you want to remove it.
Exactly. How do you remove it?
Is that the endarterectomy?
So endarterectomy is when you have atherosclerotic disease and a clot that you want to remove. You want to do an embolectomy.
Embolectomy. Yeah, embolectomy.
So Samib, do you know how to do that embolectomy?
I do not.
Okay, so it's very good. That's the best answer. You go to the OR, you put the patient on the table, you cut down on their popliteal artery, you open the popliteal, you make an incision in the popliteal artery in a transverse fashion. You get the clot out that there's there, and there's something called Fogarty catheter. A Fogarty catheter is a catheter with a balloon at the tip, and you can put a syringe on it. So you pass the Fogarty catheter, you inflate the balloon, and you pull it back, and all the clot will come out. You do that for the inflow, and then you do that for the tibial vessels, all three of them, because you cut there. And then once you get all the clot and you don't have any more clot, you stop, you close the blood vessel, and you open your clamps, and you have blood flow back. This is one way. This is called a surgical embolectomy. Nowadays, we do a lot of endovascular stuff. Any idea what we can do with the endovascular? Use your imagination, even if you don't know. Think about it. You have a clot. You can be inside the blood vessels with catheters and wires. Use your imagination, although you do not know the technology. Tell me, what can you do?
If you're putting something into the vessel, you could maybe have some sort of instrument at the end of it that can kind of break through the clot. But I feel like that'd be risky in terms of further embolization.
Right. I mean, she's packed. You don't want to break it. What do you want to do with it, Jeremy?
Could you, isn't there some sort of like procedure where they put like some sort of net distal to the clot and they like sort of bust through the clot and the net catches it and then you continue?
You're right. In the brain, there's something like that you can do. It's called an embolectomy catheter. You can do that. But is there something that can be like a little easier than that? Can you suction it? Yes, yes, you can. Yes, you can. You can suction it. You know, you can use a suction device and you can suction the clot. In order to make the clot a little softer, you can put a catheter there across in the clot, because usually the wire and the catheters go very easy in the clot because it's not formed yet. It's just happened. And you can give TPA, right? TPA, catheter-directed lysis. TPA will break the clot, and you can remove let it sit for 20, 30 minutes, to remove the catheter, and then go in with your suction and suction it. It's a suction thrombectomy catheter, actually. You hook it to a pump. It's pretty cool. Or if someone has some blood flow to their foot, not like this lady, has some blood flow, you can leave the catheter overnight, and the next day come in and see if there's any more and suction it out. So basically, those are the three ways: either overnight lysis, or you do everything same day with a catheter and wire, or you take them to the OR and cut down on them and use the Fogarty catheter. So those are the three ways that we can do it. Now, what did this lady have?
Acute limb ischemia.
Correct. Who knows the classification of acute limb ischemia? The Rutherford classification of acute limb ischemia. Somebody does?
Isn't it like a 6 or like it's like ranked 0 to
Oh,
6
no.
with increasing? Oh no.
1 to 6, Rutherford class 1 to 6 is for chronic limb ischemia.
Okay.
Rutherford 1, 2B, 2A, 2B, and 3 are for acute
Mm.
limb ischemia. Rutherford
I see.
1 is they don't have, they can move the leg, they can feel the leg, and they can they have Dopplerable signals in the arteries and in the vein. Rutherford 2A is they have decreased sensation, but their motor is intact. So Rutherford 1, you can wait on them. Rutherford 2A, they have intact sensation, but they, I'm sorry, decreased sensation, but intact motor, could have arterial signals, definitely have venous signals. Then those patients, you can wait on them 12 to 24 hours before you treat them, which means if I'm on call, I'm on call tonight, and someone comes in at 10 p.m. or at midnight, I don't have to go and operate on them at midnight. They're not gonna lose their leg. I'll go in the morning and do it. Rutherford 2B, is when they have decreased sensory, probably no arterial signals, but they have venous signals, and it's an emergency. I have to treat them right away or they will lose their leg. Rutherford 3 means they cannot move the leg at all, they cannot feel it at all, they don't have arterial signal, they don't have venous signals, and it means that no matter what you do, this is not a salvageable limb, and they need an amputation. Okay, so this lady, because Samip wanted to do a cardiac workup on her, it took about 4 or 5 hours before we got her to the operating room, and we were able to take the clot out. Is there something we should do now?
Put her on some type of chronic medication. So like,
For sure, she needs to be on anticoagulation, right? She has a fib, she needs a cardiology consult, all that stuff. But while you're in the operating room, is there something you should do? She had 6 hours of ischemia.
Should we check for levels of like creatinine or I think that we should check for creatinine kinase because we're going to be reperfusing tissue that's been ischemic for a long time, which can, I guess, release some toxins.
What can it cause?
Rhabdo, I think. I think that it will cause rhabdo. Getting better at the language.
So what you're talking about is you're talking about compartment syndrome, right? So when you reperfuse a limb that has not been perfused for 4 to 6 hours, there's a risk of the muscle swelling because of all the inflammation that goes on there. And then because of the fascia of the muscle, the muscle will become necrotic and die because of the congestion, and all the small venous vessels will be collapsed because of the pressure, and the muscle will not get enough blood and oxygen and it will die. What do we do for compartment syndrome?
you cut the fascia.
What do you call that?
Fasciotomy.
Yeah.
Fasciotomies, right? So those patients, you do the fasciotomy, before they develop the compartment syndrome. So when someone has 4 to 6 hours of acute limb ischemia, you need to do fasciotomies before you leave the room. So before we leave the operating room, we preemptively do the fasciotomies, okay? And then, of course, you put her on a blood thinner. She needs to be on a blood thinner for sure, and she needs to have a cardiology follow-up. Okay? Any questions on that? Good. All right. So the third thing we do is about abdominal aortic aneurysm. Usually, I don't give a case. It's just you have a 65-year-old gentleman that his primary care referred him to you for a 6-centimeter AAA. How do we work up a AAA?
Ultrasound.
Ultrasound for surveillance for sure, or for diagnosis for sure. But he has a 6-centimeter AAA. Do you think we should fix it? What is the size criteria to fix a AAA?
Greater than 5.5 centimeters, or I think it's enlarging by 1 centimeter every year or 0.5 centimeter every year.
Okay, so greater than 5.5 centimeters in men, or greater than 5 centimeters in women. or enlarging more than a centimeter per year, or half a centimeter per 6 months.
6 months.
Okay? Or if it's symptomatic. What are the symptoms that can be from an aneurysm?
Pulsatile mass in your abdomen.
Not a symptom.
Back
Oh.
pain.
Back pain, abdominal pain. What else? It's a mass. What can a mass do?
Rupture.
Yeah, I mean, that's a ruptured aneurysm for sure, but it can compress ureters, right? So compression. What happens in the wall of the blood of the aneurysm usually?
It could create a thrombus.
Thrombus, and it can embolize, right? So all these pain, compression, and thrombosis or embolization are an indication for fix them, even if they don't meet size criteria, okay? But then when they're greater than 5.5, you have to fix them. When they're greater than 5 centimeter for women, you have to fix them. Now, let's say you have a 65-year-old gentleman coming to your office for, you're a cardiologist, and they're coming to your office for high blood pressure. Do we screen people for aneurysms?
Yes.
Who?
Men who are smokers and greater than 60.
Wow.
65.
64. Greater than 64. So all Medicare population, actually Medicare will pay for it because it's been shown that it will actually save lives. So do you know how many cigarettes do they have to smoke their lifetime to qualify for this? 100 cigarettes. That's like 5 packs, their whole lifetime. If they smoked 100 cigarettes in their lifetime, they need to be screened for an abdominal aortic aneurysm when they're older than 64. Okay, women, do women have any screening? There's no recommendation to screen women nowadays. If someone has a strong family history and they're smokers and they're older, we typically will screen them, but there's no recommendation to screen women for aneurysm at the moment. Let's say this guy has a 6 centimeter aneurysm. How do we work it up? We want to fix it. What do we need to do before we fix it? How can we know the exact anatomy?
Oh, CT or MRI?
CT angiogram is the best thing to get, okay? It will tell you the relationship to the renal arteries, the relationship to the iliac arteries. Are they involved? Not. How is his access? Let's say it's an infrarenal. You have a decent normal piece of aorta below the renals for about 2 cms, and it's like a nice 6 centimeter aneurysm, and then the iliacs are well. How do we fix it?
By stenting?
What do you call it? So it's an endovascular aneurysm repair, right? EVAR. You heard that term before? Yeah. So it's a covered stent that you put in to exclude the aneurysm so there's no more flow to the aneurysm. It's a very cool procedure. When you guys come to the hospital back to your surgery rotation and you're rotating, check the OR schedule, and if there's something on that we're doing an EVAR one day, you come into the room, introduce yourselves, and say, I want to watch this and see how it goes, and you can see how we do it. It's really cool. Most patients can go home the next day.
I have a quick question.
Yeah.
When you're stenting, how far on either side of the aneurysm do you need to go to ensure that there isn't any blood flow that kind of escapes this?
So to get a good seal proximally, usually if we're talking about a complete infrarenal aneurysm, most devices that are there in the commercial devices need 1.5 centimeters of proximal seal of normal aorta below the kidneys, the renal artery. Okay. There are some devices that need only 1 centimeter. So it's 1 to 1.5 centimeters. And usually into the iliac arteries, you need at least 1 centimeter of good seal to get it. But the more you can get, at least 1.
You said proximal. What about distally?
No, I'm saying proximally, some devices are 1, some devices are 1.5. Distally into the iliacs, right? You have to go into the iliacs, at least 1.
Okay. Understood.
What's another option to treat an aneurysm that is super cool? It's a big open surgery, right? You zip the guy open like this, or you do retroperitoneal approach, you open the aneurysm sac and you suture a bypass graft. Okay, it's very cool. Most aneurysms, more than 80% nowadays, or actually more than 90% of aneurysms in the United States are treated with EVARs, but we still do an open every now and then. Okay, so this is for aneurysm. Now we're gonna do a carotid case. You have a 65-year-old lady who is in the hospital because she has acute left arm weakness. So I'm gonna go over this quickly and then we'll discuss. So it is started like a few hours before. She felt that she went to pick up her bottle of water and she dropped it without knowing. She doesn't know why. And then suddenly, whatever she told her left arm to do, it wouldn't do it. It was also a little numb. Actually, it was her right arm. And then she couldn't speak very well. Whatever she said, nobody understood what she was saying. And this started about 30 minutes ago, and then she came to the emergency room. What are we worried about?
A stroke.
A stroke, right? So what's the difference between a stroke and a TIA?
TIAs usually resolve in a couple minutes or resolve on their own.
What is the definition? Within what? Stroke symptoms that resolve within
5 minutes?
24 hours. So if you have symptoms that resolve within 24 hours, you're right. Most TIA symptoms are fleeting and brief. But the definition is if it's a stroke symptoms that resolve within 24 hours, then it's a transient ischemic attack or TIA. If that stays more than 24 hours, then it's called a stroke. Now, carotids, the vast majority of strokes are ischemic strokes and not hemorrhagic strokes. And the carotid artery could be one of the big culprits of, sending embolic stuff to the brain for the ischemic strokes. So this lady came to the hospital, and while she's in the hospital, her symptoms completely resolved. She has hypertension, congestive heart failure, diabetes, never had surgeries, doesn't take any medication, no family history, no surgeries in the past. And her symptoms are completely resolved while you were examining her. So we got some vital signs and they were normal. She was a little bit hypertensive. Her heart rate was regular. Her chest was clear. Her belly was soft. She had no edema. She had palpable pulses everywhere. So what do you want to do for her?
Do an echocardiogram?
It's part of a stroke workup for sure. Her echo was normal. What else? First thing you do when you're suspecting a stroke?
Cerebral angiography?
No, you do a CT scan. First thing you do is the CT of the head. First without contrast, and then you give them contrast. First without contrast to see if there's any bleeding there, and then you give them contrast and you repeat the CT scan. You see if there's any large vessel occlusion. If there's any large vessel occlusion, then there's a window to decide if you want to give them systemic TPA or not, which means TPA through the IB to deserve the clot. You learn more about that with neurology. Here we're going to focus on the carotid arteries. So they did a CT. There was nothing there. No large vessel occlusion, no hemorrhage, no occlusion, nothing like that. Usually the CT code stroke include a CTA of the neck to look at the carotid. You look at the CTA of the neck and you see that there is 60% narrowing on that left carotid artery. And what is another study that we usually do to look at the carotid artery? A duplex, is that what you said?
Yeah, duplex.
Yeah, for sure. An ultrasound duplex of the carotid artery is the most important study on a carotid artery. CT scan is also very good. What is the gold standard? You guys know what is the gold standard?
Is it ultrasound, like duplex?
Angiography is actually the gold standard, but we don't do that anymore. People used to get an angiography before any carotid endarterectomy, and the angiography alone has 1 to 2% risk of stroke. So we don't do that anymore. CT angiogram, I think, is way better. Sometimes you still have to do an angiogram, but very rare. So usually ultrasound and a CT angiogram. So she gets an ultrasound, and the ultrasound shows that she has about 50 to 69% stenosis on the left side. On the right side, she has greater than 70% stenosis. And this is based on velocities. You don't have to remember the velocities for the narrowing, I don't think. So is this a symptomatic patient or an asymptomatic patient?
Symptomatic.
Okay. What is the narrowing to treat a symptomatic patient? How narrow should it be?
Above 70%.
Right. This is what the book tells you, right? This is what NASA told us, that above 70%, we treat the patients with carotid stenosis. In real life, everyone with stenosis greater than 50%, they are symptomatic, we treat them. Okay? The book still says 70%, and I don't know when this is going to change. Is that what your book said, 70% for symptomatic?
It says that 50 to 69% is like less effective. The CEA is much less effective.
Right, this is for NASA, but we typically, anyone greater than 50% stenosis who are symptomatic, we treat, okay? And then how about for, so this lady has 50 to 69%. The book is gonna tell us not to treat her left side, right? Because she has left side symptoms, right arm, right hand, speech issues, right? The book will tell us not to treat her. I will treat her for sure. Me and every other vascular surgeon outside will treat her. But she has also 70% on the other side, which is asymptomatic, right? So which one do you treat first if you have a symptomatic side, but an asymptomatic side that is narrower than the symptomatic side? Which side do you treat first?
The asymptomatic side, since it's narrower.
It's a 50-50 guess, right? No, you treat the symptomatic side first. Okay, even though the other side could be 99%, you always treat the symptomatic side first. So we treat the symptomatic side. What is the criteria to treat asymptomatic carotid? What's the narrowing should be?
Above 80%?
Is that what the book is telling you?
I think so, yeah.
The classic teaching used to be greater than 60%, okay? Greater than 60% by angiography, though. So the studies were done by angiography, and people confuse them between angiography and ultrasound. So if the narrowing is less than 70%, now 70, 80%, no one will treat an asymptomatic carotid. And I'm talking about surgery or stenting. But everyone should be on what?
Medical management,
which is
statin, aspirin, and Plavix.
So no Plavix for asymptomatic patients. Symptomatic patients maybe need Plavix until you fix their carotid. After that, you fix them. There's no studies that show better effect with dual antiplatelet therapy. So aspirin, statin, good control of their medical management, smoking cessation, right? So every patient should be on those with peripheral arterial disease and atherosclerotic disease, because this is atherosclerotic disease, right? So yeah, so we decided that we want to treat it. We want to treat the left side. How can we treat a carotid stenosis?
Endorectomy.
Okay. You know what that means?
You like go in and basically scrape the atherosclerosis off.
Right. And then how do we close the vessel?
You just stitch it.
You can do primary closure when people used to do that. So you open the blood vessel longitudinally, right? Not transversely, longitudinally, and you scrape the plaque out and part of the intima as well, right? And then you close the blood vessel. When they found out is that when you close them primarily, they have restenosis and they have strokes or a higher chance for strokes. So now every time what we do is we use a patch, a bovine pericardium patch, and we do patch angioplasty. So endarterectomy and patch angioplasty. So you kind of create a roof for that blood vessel to close it, okay? Is there another way to treat a carotid?
Stenting?
Stenting. So there are two ways to do the stent. Do you know which ways?
No, I do not.
Anyone knows? So you can come from the groins with wire and catheter and go and put the catheter there. You put a filter past the lesion, and you go in and stent the lesion. Okay, this is a traditional transfemoral stent. This has fallen out of favor because the CREST study is considered one of the best carotid studies done, and it showed that the risk of stroke with a carotid stent, all comers, is around 4.2%, while with carotid endarterectomy, it's around 2.1%. So patients, carotid stenting completely fell out of favor after the CREST study. So now there's a new technique to do carotid stenting. It's kind of a hybrid procedure. It's called TCAR, transcarotid arterial revascularization. Have you guys heard of this? Okay, my partner, one of my partners is now doing one of those. Also, when you're back in the hospital, look, I mean, we usually do 1 or 2 a week of the TCARs. You can come and check it out. It's pretty cool. We make a little cut, vertical or horizontal, above the clavicle between the 2 heads of the sternocleidomastoid. Between the 2 heads of the sternocleidomastoid, if you dissect down, you find the IJ, you move it aside, and you find a common carotid artery. We stick it, and we put a sheath in it. And then we put a sheath in the vein in the leg, in the femoral vein. And then we connect the 2 together. And in the middle, there's a filter. The blood pressure in the brain is much higher than the blood pressure in the leg, right? In the vein. The arterial pressure is much higher. So the blood flow from the brain into the vein and passes through a filter. So we clamp the carotid, and then we go in with wires and catheters, we balloon and we stent. So if something is to flick off and go to the brain because of the pressure difference, and now the flow is reversed, it's called flow reversal, the thing is sucked through the sheath and it will get filtered and the blood goes back to the patient through their femoral vein. It's a very, very good procedure. The whole procedure takes less than an hour. And the risk of stroke with that procedure is as good as a carotid endarterectomy. So now we do all the stenting, or the vast majority of carotid stenting is done that way. Patients that get carotid stent need to be on dual antiplatelet therapy for at least 60 days after the procedure. And then they can be on aspirin alone. Excuse me, aspirin and statin always for the rest of their life. Okay. Any questions? We're going to have any potential vascular surgeons?
Of course.
Telling you, it's pretty cool. It's pretty cool. Nowadays, you can do, we don't have a 0-5 year, but you can go straight after medical school and be, become a vascular surgeon. It's fantastic. So I strongly encourage you, come find me when you're in the hospital. I operate here at CMC Maine every Tuesday and sometimes on Fridays, but mostly on Tuesdays. Come find me and we'll see what I'm doing, and you guys can come in and check it. We'll either be doing a claudicant or a limb ischemia or a carotid or an aneurysm, and you can check what is the stuff that you read about and how it's done, and maybe get one of you interested in vascular surgery.